thank you for staying. I know it's a long day, but GI and hepatology and endoscopy are important, and it's quite extensive to talk about. So this session is about biliary diseases, and at the end of the session, we'll have the quiz. If you stay and you attended all lectures, we have 5 questions. If you answer all of them correctly, you get a chance to win a MacBook M3 Air. KGA members cannot participate. Okay? So let me introduce the chairs for this session. I'd like to ask Dr. Faisal Al-Shatti, Dr. Fatma Al-Musawi, Dr. Mahmoud Umar, and Dr. Yusuf Shimali to the stage, please.
Thank you very much. We'll start our 6th session. I would like to invite Dr. Vivek Kaul. He's a professor of medicine and the former division chief of the University of Rochester Medical Center. He's specialized in therapeutic endoscopy. He has expertise including complex intervention endoscopy, particularly in GI cancer patients. He leads and contributes to multiple national and international clinical trials in endoscopy. Dr. Kaul, please have the stage for you.
Good afternoon. Thank you, Chairperson, and thanks again for having me here. Now, finally, I have one of my favorite topics. When I was a fellow, I used to, this was a long time ago, I used to think about ERCP as being the ultimate challenge. Many years later, it became a reality that I was doing it and doing it very frequently. So one of the problems in ERCP is biliary access, pancreatic as well, but biliary mostly. And so the talk today is how to overcome these challenges, and I'll do my best to go through these. These are my objectives. I'll talk a little bit about my favorite aspects of ERCP, which are related to the basic principles and adherence to guidelines. We'll walk through some of the usual challenges and then interventions that have come in to manage these. For fellows and junior faculty, this is an important curriculum to be in your binder. This is something that should be available to you if you're learning ERCP and in your early years of practicing. Remember, these guidelines from Europe and America these are not your regular guidelines. These are very, very thick documents. They're like almost 60 pages each. There's a lot of information there, so please take a look at them when you have a chance. ERCP is the original advanced endoscopy procedure. You heard yesterday a lot about ESD and full thickness resection and all of that, but this was the original advanced endoscopy procedure. After colonoscopy was started by Shinya in Japan, this was the next big thing, and then multiple centers started this in the 1970s, and it was coined as the term ERCP at the Mexican World Congress in 1972. So it remains today the most risky advanced procedure, and I'll show you why. It is primarily therapeutic now, and it is potentially life-saving, but it also be very, very painful when you have a negative outcome from ERCP. I know a physician personally from India who had a very, very negative outcome, went into exile for 10 years because of the trauma, mental trauma from that, and came out and has written a book which is titled Resilience. It's available on Amazon. So ERCP can be very, very impactful. To me, it remains the most risky procedure because for bleeding, perforation, infection, we have very clear solutions. But for multi-organ failure from pancreatitis, we have no solution still. And these patients end up in the ICU, so be very, very careful. My feeling is that for ERCP to have good outcomes, you need proper training, you need a team, you need infrastructure, you need excellent patient selection consistently every day, and you need to adhere to best practice principles. So in terms of how to train well and how to achieve competency, this is a very important paper from Sachin Vani, my good friend in Colorado. Look it up, please. It is the only paper that is in recent times that talks about the training and evaluation and assessment of competency for ERCP and EUS. And these are the criteria listed. In fact, if you're training somebody in ERCP, this is the exact stations and milestones that need to be captured. And no other document has this. So please take a look at this. This is the team approach. This is some of these people have left, but this was our original ERCP team with the providers and the APPs and the nurses and the technicians in the back. Now, there is also a new information in the nurses and technicians area. Again, when you're overcoming a difficult challenge, the team is very, very important. There is a new ASGE curriculum for techs and nurses. Please take a look at it. GS Raju from MD Anderson has helped develop it with the state of Texas. It took about 7 years, but finally it is out, and it is the only formal structured curriculum for ERCP and endoscopy techs. So please take a look at it. The other thing that has become very clear in recent times is that post-COVID staffing, at least in America, is a big challenge. So a lot of the people that are working with us nowadays are traveling nurses and traveling techs. They are not our 10, 15-year-old experienced ERCP techs and nurses. So that's become another challenge to overcome. Room setup. This is very important. This is stolen from Peter Cotton's original book that he wrote with Christopher Williams. It's no longer available. I had that book. I think it's somewhere in my basement, but I stole this picture many years ago because this construct for the ERCP room setup still remains very true to today, and this is how it is set up. This was one of our original $2 million rooms. This was 15, 16 years ago that we built it. I think a room like this would cost about $10 million today, but you need to have that kind of a setup to have a good procedure. Now, most important challenge in my mind is the cognitive challenge. Who should be doing ERCP? For what reason? What am I doing with this case? What is my approach going to be? What equipment do I need? And what is my plan B and C? If you don't overcome this mental challenge first, you're not likely going to have a good procedural challenge navigation. So this is a very important slide in my talk, is understand what you're doing, why you're doing it, and how you're going to deal with it. So therefore, the 3 most important questions are, what is the indication for the procedure? Have I done a proper anatomy check? Nowadays, patients are coming after gastric bypass and other type of procedures, and you don't want to find that out when the patient is already intubated. And do I have the correct equipment? Supply chain becomes a problem nowadays. We have many days when we don't have a certain needle or catheter in the unit because it's still on back order. Be very careful when you start a procedure that you have all the equipment. Now, a concept of difficult ERCP comes up. What is difficult ERCP? Some scenarios are difficult for all. If you ask me to do a Whipple case or a Billrod 2 case, it's going to be challenging no matter what. It's not going to be the same as doing a 20-year-old with a virgin abdomen. Some scenarios are difficult for some. For example, ampulectomy. It is not every ERCP person who can do ampulectomy safely and competently. So yes, there is a moderate to severe level of difficulty. But some scenarios are made difficult by yourself or by your team member, such as indiscriminate submucosal injection. Once you have a submucosal injection, game is over for that day, especially if you're using a full-strength contrast. So difficulty is a relative concept, and I wanted to put that out there. One of the important things to realize first is that most cases of successful and efficient biliary cannulation are usually only achieved with a short scope position. When the scope is in a very altered position, it's very difficult to do a good job. In that particular case, I had to do that position, and that's the only position that worked. But in general, the slide on the left is where you want to be. Patient selection. Appropriate indications are lifted on the left, and inappropriate indications are listed on the right. Even today, even in America, a lot of ERCPs are being done for abdominal pain. That is absolutely indefensible, and if you have a complication from that, you're going to be in serious trouble. So pay attention to this slide. The left side are the appropriate indications, the right side are not, including the surgeon requested the procedure. There is no such thing in the ERCP textbook that says surgeon requested the procedure. We don't do that, right? And this was actually solidified by Peter Cotton's trial, the episode trial. The episode trial basically was a randomized sham control trial for type 3 SOD, and it made it clear that there is no role for ERCP in abdominal pain patients. Peter Cotton further followed it up by reporting his lifetime experience of all the lawsuits he had in ERCP. This is an amazing paper to read. It's very interesting. If you are bored sometime, read this paper and you will realize what he went through and what his opinion was. It's all about indications, all about indications. Now, biliary access is the most common request for ERCP, and most of us still, even though however complex ERCP we do, biliary access is the most common indication. So here are the pearls and caveats for biliary access. Okay, so wire-guided access is a randomized controlled trial-based evidence. You have to preferably go with wire-guided access. Once you have biliary access, you should never be lost. And without biliary access, you cannot even begin to do therapeutics. Remember that it's not even always possible, even with experts. Sometimes even experts have to come back another day, and that's okay. And it's also okay to abort a procedure and refer the patient on to a different center, different person, or completely go to plan B or plan C. It's all right. The patient and the family will never fault you for backing away, but they will be much more upset if you kill the patient, right? So basic ampullary and ductal anatomy. It takes, even fellows who come after advanced endoscopy fellowship, it takes at least 2 years or 3 years for them to understand this slide. This is the most important slide in ERCP learning. Where is the access of cannulation of the bile duct? The green arrow is the only way to go. If you go straight, then you go into PD. So if you don't understand this sagittal section of the ampullary anatomy, if you don't translate that from your brain to your hands, you're not going to be successful. So very important. And of course, papillary anatomy is highly variable. Do you have a favorite papilla? Well, mine is the number 3 on the top, right? Because even if I don't get it, I can do a needle knife, right? But papillary anatomy can come in very many different. And once I look at the papilla, I already look at the nurse and say, oh my God, not this papilla, not today, right? But it happens. We get all types of papillae, and they can be very challenging. Number 2 can be really challenging, especially. And if you don't have a taper tip catheter, a small guide wire, you can be there all day and you're not going to get that bile duct. So realize that papillary anatomy is very important to take into mind. And my approach to papilla is not to fight with it. No fighting with the papilla, okay? It's not an adversary. You have to negotiate with the papilla. Negotiate, like a good negotiator, like Denzel Washington, right? In The Hostage Negotiator. Now, this is a slide I created. It is not in any textbook. Feel free to take a picture of it. So successful biliary cannulation, this overcomes a lot of challenges. Short scope position, controlling motility in the duodenum, approaching the angle, like I said, 11 o'clock location from below, and then of course, on the lower end, you have the small movements of the small right wheel, the big wheel coming towards yourself, and constantly kind of adjusting your body position and your scope position to get that appropriate angle that takes you to the 11 o'clock. So this is an important, all these things are happening at the same time, and that's why it takes 3 to 5 years after advanced endoscopy fellowship to become consummate with biliary cannulation. Consummate means that you can do it with elan, with elegance, with finesse, and you come out ahead most of the time. Now, when you cannulate the papilla, there's a lot of options for device and catheters and so forth. This, again, is like a book-like document. It is like 40 pages, and these obviously keep getting revised by companies. So know which cannulation devices you're using and how you're doing it. Here's an example of a potentially difficult cannulation, because look at the papilla size and look at how big the catheter is in comparison to the papilla. But here we use selective wire-guided cannulation. Look at the angle of approach. I freeze the video in that just to show the angle of approach. Bile duct and PD, 2 different angles. See the alignment. Unless you get this alignment right, you're not going to come out ahead. So this is a very important point. And then the video proceeds, and we show that the wire-guided angulation will go from there. So, the most common challenge, of course, is difficulty in cannulation, and these are the more advanced techniques for cannulation. I usually start with a double wire technique, which is the safest, and then you go from there with transpancreatic septotomy, which was developed by John Goff. He's still a practicing gastroenterologist in Denver, Colorado. Great guy. And then, of course, you go with needle knife fistulotomy or papillotomy, and then sometimes, you know, our Far Eastern colleagues have shown us that ampulectomy may be the way to go, but we generally don't do that unless you're dealing with an adenoma. So here's a double wire technique. You have the first slide showing the wire in the pancreatic duct, and then you go on the left side of it. Unless you go on the left of it, you're not going to get the bile duct. And then you get the two wires. At that point, it's your choice, depending on your concern. You may or may not leave the pancreatic stent. I usually do, but you finish your bile duct therapeutics at that point. The second problem comes as a diverticulum. Now again, with the diverticulum, you see the angle of cannulation is still the same principle. You come from below, you have a hyperbow on the catheter, sphinctertome, and then you try to get the guide wire in that direction, and you manipulate, you move around a little bit until you don't jam the catheter, you don't bloody it up, right? So you get the wire guide in there, and then you follow that up. So diverticulum cannulation comes with time, and you have to work it. So the next challenge is, when all else fails, then you have to try the needle knife. The needle knife was one of the greatest advances in ERCP that was developed. And you can see here it's a layer by layer incision to get that. Obviously, this is a very generous papilla, so it's easier to do it. But I think if you're going to be doing ERCPs, you have to learn needle knife access. And usually the best way to learn it is over a stent. So when you have returning patient coming after with the stent placement, try it slowly over the stent. It's a protected area. And then try the cannulation with the guide wire and never force the catheter. This is the needle knife catheter, and many variations are available. It's a monofilament wire. Now, selective pancreatic duct cannulation is the opposite of bile duct. So here, the goal is minimum contrast injection, again guide wire cannulation, but while avoiding side branch perforation. So that's another problem. Side branch perforation, you get severe pancreatitis. Here you can use a reverse double wire technique, which means bile duct wire first and then pancreatic wire. It does work as well, and sometimes you have to use rendezvous technique. So PD cannulation is described in this slide. If you see, as opposed to going from below to the 11 o'clock, for the PD you have to stand straight looking at the papilla. Looking at the papilla at the same level, so it's almost, I call it the ground floor entry. Straight in, and that's your best chance. Obviously, if the catheter keeps going into the bile duct, then you have to manipulate it and pull it back until you are straight. And slide C here shows how straight the scope is to facilitate pancreatic entry. This is very, very important techniques, but the saying goes is that the day you need the pancreatic duct is the day you don't get it. So here is the wire-guided cannulation showing you a wire first in the pancreatic duct, and you can see that the upstream duct has minimal contrast in it, and then there is no contrast in the downstream duct. It's a long stricture, and then we place the stent over there. So I don't fill up the whole duct with contrast, and you can actually even suck out some of the contrast before you leave the case. Contraindications to ERCP are listed here. Obvious contraindications, but the most important is the lack of a guideline-supported indication. That's very, very important. Complications of ERCP is not a part of this lecture, but I just wanted, for the sake of completion, mention it here so that we go through that real quick. Obviously, post-ERCP, pancreatitis is the most common complication. There's another very, very good document here called Adverse Events of ERCP. Please look it up. It's got pretty much every state-of-the-art management recommendation. It should be in the binder for fellows and so forth. Challenging situations for pancreatic and biliary access are listed here. Obviously, a large diverticulum, difficult upper esophageal sphincter, Zenker's diverticulum, difficult stomach, duodenal stricture, you name it. Everything we have seen it, and it's very, very difficult to navigate some of these. But the most important challenge is the endoscopist expertise and experience. The more you struggle, the more better you get if you apply the learning from the last case to the next case. If you don't apply the learning, you're not going to get better. Options after failed ERCP. Repeat ERCP on another day, send them to another person. Of course, in those centers that don't have EUS type of access, and then IR and PTC is certainly fine. And for appropriate indications, patients still need to go to surgery. This is an example of a double balloon scope trying to do ERCP in Roux-en-Y gastric bypass. And then, of course, this is one of the largest studies we did on laparoscopic transgastric ERCP, and it's the largest data set I did with Peter Dragunov, and we started that procedure 20 years ago at our university, and now it's kind of falling away because of the EUS-guided approaches. This is, of course, the EDGE procedure, known as the EUS-directed transgastric ERCP. This is an example with a video showing examination of the pouch and the efferent limb. This is the typical appearance of the excluded stomach. 19-gauge needle, go right in there, put the methylene blue, fill it up, aspirate it, And then there is your fluoroscopic image, and then you put the lumen opposing stent directly into the space. This is working out pretty good for Roux-en-Y gastric bypass right now. We prefer the two-stage procedure where you do the LAMS on one day and 2 weeks later we do the ERCP. So it doesn't work for cholangitis, but it works for elective indications. Last section, EUS-guided biliary drainage for failed ERCP access is a very, very avant-garde segment of procedures. This is recommended both by the ACG now and the ESGE as primary or even a secondary or even primary indication. Like if you see on the right side, you can even use it as a primary drainage at expert centers where you have a lot of skill in this. These are the standard pieces of equipment. On the left side is the cystotome, right side is the lumen opposing stent, and a variety of double pigtail stents. So how do we do this? The most basic of these is the EUS-guided choledochoduodenostomy. That's shown in this video. You puncture the bile duct from the duodenum bulb, and then you put the lumen opposing stent through that. In the old days, we were putting fully covered metal stents, but there used to be leaks even with that. So nowadays, we do it with the LAMS. And you first confirm. Nowadays, you don't even need to put the cholangiogram because if the bile duct is very big on EUS, you can put directly the LAMS. So here is going the lumen opposing stent and dilating balloon. And so that's one way of doing it. And it's very good for patients who have obstructed duodenum or don't have easy access. So here is the lumen opposing stent coming out. And soon we can see that. Going over there. All right, and this, what is the data on this? So this is one of the largest studies a couple of years ago, EUS-guided choledochoduodenostomy from the Italian group. The success rates are good, but there is still a decent adverse event rate. So I think we'll have to get better with the devices and make sure that we don't have too many complications. This is actually one of the only randomized trials between direct EUS-guided biliary drainage versus ERCP drainage. And you can look here that all the aspects were pretty similar. But the procedure time was much shorter, obviously, with the EUS-guided approach. And it was published in gastroenterology. Very few endoscopy papers are published in gastro. Very high-quality study that you should look at if you haven't looked at it. There's also guidance now on adverse events after lumen opposing stents, and that is the so-called Leuven-Amsterdam classification. It goes all the way from sump syndrome all the way to gastric outlet obstruction. People who are doing these procedures should know about this classification and also very recently published. The most complex of the biliary access procedures is EUS-guided hepaticogastrostomy. This is going from the stomach into the left lobe of the liver. Not an easy procedure. It has probably the most risk and technical challenges. You can see here a left intrahepatic radical has been entered, and then from there you put the guide wire and you dilate the tract. We still are a little bit behind in the kind of devices for this, but at expert centers it is being done with some degree of facility. You can see here, here's the dilation of the tract, and the partially covered metal stent is going in. Basically, the uncovered portion will anchor it in the stomach, and the fully covered portion will prevent leaks inside the liver. So a rather complex procedure, not frequently practiced even in the big centers, but something that I think with device improvement we will be doing more of. This is the data on hepaticogastrostomy, also published actually just recently by Cecilia Binda, a good friend of mine from Milan. And she has shown that the data is pretty good, although you do need a certain number of cases to actually be very, very good at this. I'll skip that. PD drainage, the ESG recommends that if you fail PD access, you can do a rendezvous technique or a transgastric EUS-guided direct stent. And here is the approach for that. From the stomach, you puncture the pancreatic duct, and then from there, you can either put a direct stent or you can do a rendezvous procedure. This is a video showing a pancreatic duct with a stone and a puncture with the 19-gauge needle. Again, a very complex procedure, not done every day. Wire into the duodenum. And then from there, you dilate the tract, and very soon you'll see a expected complication in this, which is the leakage of the contrast in the retroperitoneum. You'll see that in a second. So here you are back in the lumen, and you're needle knifing it, and you're grabbing the wire. So here's the cautery, opening up the hole, and when you do that, you expose yourself to the risk of retroperitoneal leakage, especially if you balloon dilate. And you'll see that in a second. There you go. You see the yellow arrow? So when you're doing these procedures, these are not easy. They are fraught with complications, but sometimes these are the only ways of delivering the job. Here is the data on the EUS-guided pancreatic duct drainage, also very recent data, very high clinical and technical success, but also look at the stent dysfunction and the problems that come. So these procedures are well on their way, but they are not yet completely refined. Final slides, ERCP cardinal sins. Don't put the entire duodenoscope in the patient. Don't put the entire wire into the scope. Don't lose biliary access once you acquire it. Never yell at your assistant. That's not the problem. You are the problem, right? So it's important to keep these cardinal sins in mind. And when you place a stent, you own it. Okay? You place a stent, you own it. So you have to follow the patient. Take-home points. ERCP is the original advanced procedure. Biliary access remains the most important indication. It's not always possible. It's okay to stop, okay to refer the patient, okay to find alternate solutions like EUS or PTC, but keep training, keep your competency up, and always think of the patient first and not the procedure. Thank you very much.
Thank you.